Welcome, and thanks for joining us for today's HIS Talk webinar, Diagnosing the Cures Act, Practical Prescriptions for Your Success. It's brought to you by Secure Exchange Solutions. I'm Lori from HIS Talk, and I'll be facilitating. We have a panel discussion for you today, and our panelists are Dr. William Golden, Medical Director of Arkansas Medicaid, Ann Santifer, the Executive Director at the Office of Health Information Technology, and Kyle Metters, Principal at Chartlux Consulting. The discussion will be moderated by Patrick Hobson from Security Exchange Solutions. So without further delay, I'll turn it over to you, Patrick.
Great, thank you, Lori, and welcome everyone. Thank you so much for investing your time with us today. My name is Patrick Hobson, and I am the Marketing Director at Secure Exchange Solutions. We have an amazing panel today, and I'm very excited to be moderating the discussion on Diagnosing the Cures Act, Practical Prescriptions for Your Success, where we'll be talking about the CMS and ONC rules and how you can prepare for the Cures Act. Here's our agenda for today's presentation. I'm going to provide a brief overview of the Cures Act and information blocking to set the stage for the discussion, and then we'll dive into the panel and follow it with a Q&A. As you listen to the discussion, we encourage you to add questions to the chat, but before we get started, I'd like to introduce Secure Exchange Solutions. We are a health IT company specializing in cloud-based clinical data exchange and data retrieval technologies. Our platform analyzes and exchanges sensitive healthcare information to improve outcomes, compliance, efficiency, and quality. We add value to the data exchange process by reviewing and routing clinical data to support use cases such as care coordination, referral management, member management, risk adjustment, quality, and medical review. We are Direct Trust accredited and High Trust CSF certified with a network of over 400,000 registered customer endpoints and access to over 2.6 million direct participants. Our solutions accelerate health IT interoperability and reduce information blocking risk for healthcare organizations across the country. And you can visit us on our website at secureexsolutions.com to learn more. The 21st Century Cures Act was passed in 2016 with broad bipartisan support. It was a very large bill. And in addition to health IT, the act covered a variety of research and development initiatives around cancer research, drug use, rare diseases, on through to medical research and a variety of other areas. This legislation served as the basis for the CMS Interoperability and Patient Access Rule and the ONC Cures Act, both released in March of 2020. So let's take a quick look at the Interoperability and Patient Access Rule. It was issued in two parts, as noted. The first part was issued in March of 2020, and the second in January of this year, which was officially an update to the rule, and highlights and things to keep in mind. On the provider side, ADT notifications became a condition of participation requirement. This took effect on May 1st. It directed Medicare and Medicaid hospitals to send electronic ADT notifications to their primary care provider and any other stakeholders designated by the patient. On the payer side, the rule added a variety of APIs, most specifically for payer to provider, payer to payer, and payer to patient exchanges, as well as provider directory lookups. The rule also added API support for prior authorizations. And this rule mandated payers to exchange comprehensive health claims data with members. In addition, on the ONC side, what we simply call the Cures rule, they updated certification requirements, added Smart on Fire and Fire version 4, and basically defined information blocking. And most noteworthy about this rule was that it standardizes around Fire version 4. So we'll see a lot more uniform adoption in the health IT space around Fire version 4. Finally, I'd like to touch on information blocking. It's a broad concept, but essentially it involves hindering the access, exchange, and use of electronic health information, or EHI. It also includes engaging or not engaging in activities and or decisions that enable information blocking to occur. So the rule applies to developers of certified health IT products, healthcare providers, as well as HIEs and HINs. And of note, information blocking is not just a technical requirement. It can also be about contractual or procedural practices. And now where it gets a little complicated is in the exception area, and ONC has identified 8 different exceptions to data sharing, as noted on the screen. These exceptions are well defined. They provide concrete examples of when data should not be available to be exchanged, accessed, or used. And our panelists will unpack some of these concepts in more detail. At this time, I'd like to get our panel engaged, and I'm going to turn it over to them for brief introductions, and then we'll get started with the questions. And to start us off, I would like to ask Dr. Golden to go first.
Good afternoon, everybody. Thank you for tuning in. I'm Bill Golden. I am the Medical Director of Arkansas Medicaid. We oversee a extensive primary care medical home, patient-centered medical home program for the last 8 or 9 years. We also work closely with Ann Sanifer and her staff. I've been involved with alternative payment models, such as a steering committee for the national LAN on alternative payment models. So happy to be here to talk about our perspectives.
And Ann?
Hi everyone. Good afternoon. I'm Ann Sanifer. I am the director of our HIE for the state of Arkansas. We are SHARE. We are the only statewide HIE for the state. And SHARE is a little bit unique because here in Arkansas, we are part of the health department, which to us, it makes complete sense because the health department requests a lot of data from providers. So having the HIE sit under our Department of Health made sense, so we can provide them with data as they needed to for all their registries and all that good stuff.
And I'm Kyle Metters here with Chartlux Consulting. We provide strategic guidance, practical implementation solutions to providers as well as health IT developers in supporting the various regulatory requirements from the ONC and CMS. Work with a lot of vendors across the spectrum on that, and as well as some provider groups. Before that, I was a director of the testing, EHR testing at Drumming Group, one of the certified certification testing bodies with the ONC for the ONC program. Been a part of, I've been a member of the Health IT Standards Committee and some other various groups in the standards space of Health IT.
Great, thank you very much, and very excited to be moderating again. For the discussion, the way it's going to work is I'm going to pose a series of questions to the panel, and each panel will have an opportunity to respond, and we'll also have some cross-panel discussion. And I would like again to start with Dr. Golden, and I'm going to introduce the first question, which is what has been the biggest obstacle with health IT interoperability, and how do you see Cures addressing it?
Well, I think the Cures Act is a wonderful opportunity to really make progress that really has been kind of stagnant for a long time in terms of improving information at the site of care. And I think we've seen in the past problems with versioning, information sharing across different EMR platforms, sometimes within practices at different sites with different versions of the same software. And then we have issues about hospitals not wanting to share data with other healthcare systems or having their data exposed. I think this is well overdue. And when you can start to see how data can be integrated, it's going to be a challenge, I think, for some practice sites because of the economics of integrating the new capacities into their existing software, but also taking this information and integrating it into their practice environment, in their business plans, and their operations. I think everyone is going to need to be up to speed on how this technology evolves and be able to implement that into their daily activities, because I can tell you, as more information becomes available and you make it available easily while you're seeing patients and making care plans, the ability to reduce care gaps and to better serve patients will just grow over time. So it's an opportunity and a challenge, but I think it's really high time for the healthcare system to be able to adopt this kind of opportunity.
Great, thank you. And Ann, would you like to go next and give your point of view on this question?
Yeah, when I think of obstacles for data sharing, I think there's always been a willingness problem with providers. It's I may share this data if I have to, but there's never been I must. I'm required to share this data. And I think from the provider's perspective, there is some infrastructure that they have to set up in order to share that information. They have to engage with their EMR vendor to set up, interfaces and pipelines to different organizations. And that's costly. So I think there's been a willingness problem of wanting to share that information, and really seeing what is that return on my investment. Yes, I'm going to set up these interfaces to share this data with others, but most likely my payer is still going to come to me and ask me to pull charts, or I might still be faxing documents over to others. So I think the Cures Act, making it a requirement, it's going to make it more broad and more acceptable. And providers they're going to have to participate in it in order to comply with the rules.
And Ann, isn't that part of your function as the HIE to try to smooth over and make those kind of integrations easier?
That's right. So, and that's where I think HIEs are, you're right, Dr. Golden, really can shine at this point, because interfaces cost money. And so creating pipelines to various organizations is going to be costly. So what we're approaching our providers here in Arkansas with is, hey, we are the data aggregator for the state. We have connections to almost all the hospitals already. We have pipelines to our primary care physicians. Thanks to Dr. Golden's very successful patient-centered medical home program, they're already being fed this data. So it's just an additional benefit to the providers when everything comes across in that one single interface and that single platform. Kyle, do you have some thoughts you want to add?
Well, I think if you think about the obstacles, I want to go back, think about, there's probably three things that come to mind. I think first, there was always this confusion of really what it meant to be interoperable. I mean, people would throw that word around, and it's kind of hard, and so I think with Cures, you're starting to define things. You talk about the ADT, you talk about FHIR version 4, we're starting to get kind of the things you should be doing. And I think information blocking tells us what not to do. So we're starting to kind of narrow that term. So I think that's one thing that frankly just helps. I do think one thing that was kind of missing too was sometimes a lack of maybe a widespread or a common use case across all the actors. I mean, I always think about how successful e-prescribing was, right? Because it was a really, really, well-defined interface, purpose, the actors knew what they needed to do. I'm hoping now with Cures, we can start kind of getting everyone kind of aligned on that. I think, before, with less data being accessible, it made some of the value-based care type of, hint that we wanted to do harder to do. Now that more data is available, I think that should open that up. And that's one thing really I think Cures will do, is really kind of accelerate some of this push toward value-based care. I think the other thing, frankly, that was hurting is just a lack of, I think we kind of touched on this some, but Dr. Golden mentioned, but just the kind of lack of specificity with kind of your interoperability elements. And so now we've got this USCDI concept. It's going to be updated every year. We're now standardizing on that, FHIR version 4, the smart on FHIR, how you're going to launch your apps. I mean, I think these are all the things that we really kind of need. Maybe there was some lack of willingness, to do this before. But there were some excuses they could point at, right? Well, now we're kind of clearing those things out. And, my hope here is that, Cures is really we have been doing work in health IT to get us ready for this time, but there has been some obstacles. Now we're trying to clear those out, working on some clear things that we need to do, right? Now let's kind of see this going forward here to really kind of build on this and what the next couple of years looks like.
Great, thank you. If I could just go back real briefly and just ask a quick follow-on question to Dr. Golden regarding the data availability. What is the strategy for Arkansas Medicaid regarding data integrity and patient incomplete patient charts and stuff like that? Some of the things Yeah,
it's a good point. I was going to say one of the things that's a challenge, and as Kyle mentioned, getting use cases going forward. We have been our medical home program, every year we review the requirements for being a participant. So several years ago, we required everybody be part of the health information exchange. And there was a little bit of grumbling, but that gave everybody a common link and then let the health information exchange develop the capacity to provide all the ADTs that could help people manage post-hospitalization care, post-ER care. And then we could turn that around and make a business case for managing your rates of hospitalization or your rates of ER use. And so, we have now been looking at, working with folks like Cher and our claims data and developing mechanisms of integrating our claims data with the data extraction from the health information exchange to give a more granular report to all the primary care sites, to give them their care gaps, and to give them kind of almost real-time or near real-time information about what their patients are or not getting in terms of required care, expected care, and who's falling between the cracks. So again, it's an opportunity to really give an information-rich environment to our primary care universe, let them see what's going on outside of their walls, and then turning around and giving new expectations of how these practices should use this information in terms of developing comprehensive plans for their patients.
Yeah, that's a really good point about the blending of, it's not just claims data, it's not just clinical data, it's everything. I mean, that's, ONC is pushing about, this more, more determinants of health, social determinants of health type of things. I mean, I think that's the thing with Cures is now with the information blocking, in about 15 months, it's got to be, all your EHI, right? That's available, and that's a wide thing. And it's kind of challenging once that's there. How much more can clinicians now, treat patients better? When they have, they're not searching here and there to get this. Instead, it's more hopefully available in a way that's curated and presented to them. So I think it's a great point about kind of the combining of the.
You bring up social determinants of care, and you're working with state agencies to try to integrate information across the agencies because they have their own silos.
Right. Even here within the health department, we have data silos and different registries that don't speak to one another. So we're just, even internally, we're trying to come up with our own way of having a single system to hold all these registries. So then we can see that person, from their birth registry information to, any diseases or anything that may happen during that course of that person's life. So, and social determinants of health is definitely part of it, identifying those folks that need it and then matching them up with services and then following up on those referrals. Did the person actually take advantage of this resources you've given? And I think data and interoperability can play a big part in this and closing all those loops and reducing those silos to where we have all the information in one place. I think we still have a lot of work to do on that. I think providers are a little leery of asking, about questions related to social determinants of health, because then you have to kind of help meet that demand. And that, if you don't have the right tools and you don't have the right information, if you don't know who has an open bed that you can send this person to, you might not want to refer them to that place. So we have a lot of work to do, but I think Cures Act is a good way. It's a good starting point for that.
So at this point, I think we could probably talk on this topic for the whole hour, but I would like to go to question number 2. So question number 2 is, what health IT solutions should organizations implement to avoid information blocking non-compliant and comply with Cures rule requirements? And if we could, you could provide some specific examples of, solutions that you have in place or that you think might be needed going forward. And I would like to start this question off with Kyle, if that would be okay, Kyle.
Sure. So it's always good to level set. Like information blocking, it's effective now as of April, but it's in the first phase, which is just the US CDI version 1 data elements, which a lot of those you find in your common CCDA files that we have. At least those who EHRs got the certification. The harder challenge is in about 15 months. Next year, when the information blocking expands to all your EHI, right? Okay, that's a lot. It's a broad category. So I think, I've been telling people there's 4 things I would think you should do: inventory, use case, interface, automate. And so the first, inventory. I like crime shows, on TVs and movies, and they always, the crime scene, they always have to mark it off and identify all these areas of concern and interest. And I'm not sure why information blocking makes me think of a grisly murder, but the analogy is that you need to go through and make an inventory of all the EHI that's in your system. Do you really know where all that is? Can you've got to first identify that. So once you've got that, you've got your inventory, I would then begin thinking about your use cases, right? I mean, we talk about these actors involved. How are patients, what data they're going to request? What data are they going to need? What about providers or hospital partners? What about your payers? Registries or HIEs, clinical networks. Kind of start thinking through that use case. So you got your inventory, you're thinking through your common use cases, and I would frankly start off with the common ones, right? I mean, I know there's some very, it's all EHI is a lot, but what are the main ones you see that happening? And then your interfaces. This is really where the technology starts coming in, right? What are the interfaces, mechanisms of exchange? You mentioned about some of the exceptions, information blocking. One of the powerful ones, noteworthy one, is called content and manner exception, which basically states that you need to make the data available, but maybe you cannot make it in the data available in the content or manner that was requested, but you can do an alternative one. So for example, someone wants to build an interface to exchange data. Listen, well, maybe we can't do that, but we already have this technology partner in place who can get you this data in maybe a different manner, but it's a standardized approach. It's approved. I think thinking about just the ways that data really will actually get out of your system now. And then I think automate's the last part. And I mean both automate in terms of obviously technology, but at least your process, right? And there's always going to be human effort involved because it's clinical data, right? We need to think about it before we just casually share it. But you also don't want it to be a panic every time someone makes a request for you to share your data, kind of like those old, I know people don't read a lot of paper, non-electronic newspapers anymore, but like, in the old days they had, stop the presses, right? Something new's come in. Every time there's a request for data, you don't want to have everyone just kind of stop right away and figure out what to do. You need to have some plans in place, but that's really where you do want to utilize the different technology solutions. There may not be a single one, like it may just all be your EHR anymore. You may need to have other solutions in place, but build that out there so that as you're identifying, you know where all the data is, you have the common use cases, you build out your interfaces and exchanges. So now you have technology partners that can do this in a way that's efficient. Because I think we're really concerned now about complying with this rule, but what's going to happen when all this data is just available? I mean, that's a lot of data. I mean, that's why Google and these people are successful, because they found a way to manage the amount of data that we have out there. So we want to do something similar with our technology partners who can really help us be efficient with all the data we have, both that we're consuming as well as that we're going out. So those are things I would say I would keep in mind. And I'm guessing obviously HIEs are really important for that. So I mean, I would definitely say talk to your HIE because they can help you do those things.
Right. And for us at the HIE, documenting is going to be key for sure. Document your use cases because even here in Arkansas, we have a lot of connections. We have most of the hospitals, we have most of the primary care physicians and the health plans. But now I'm getting some very interesting questions about data sharing, and people are throwing information blocking left and right. There's new information blocking rules. So one thing we're doing is documenting our use cases, documenting our pricing structure. So that way it's set, it's written down. If anybody asks, well, I'm sorry, this is not, one of our use cases. And there are exceptions to information blocking, but I really feel like for us here at the HIE, we are the keeper of medical records for everyone that lives here in the state of Arkansas. We have 3.2 million unique lives in our HIE, and I'm very protective of that data, and we're collecting a lot of it. But I want to make sure, that those that request it are appropriate and have a defined use case. And that's going to be really hard for us as HIEs to be the gatekeeper of that data, because what you don't want to do is lose the trust of those data contributors, and your health plans are contributing and making this HIE thing happen.
Okay, yesterday I sat in a conference call or a webinar with ONC talking about all the new challenges, and the Gravity project, which I recommend to folks to keep an eye on, is developed as a really large group of volunteers coming up with a whole bunch of new standards and operational items that can be used in the whole area of privacy. You start to share data, and patients access, because of the Cures Act, they can see their own data, and suddenly it ends up on their cell phone. And then because of business relationships, they suddenly discover that some app on their phone shares their data with marketers, and all sorts of odd information can get out into the webland. And so there's all sorts of new things we have to be aware of. And they're developing now consent banks to make sure people are consented to be part of the system. So again, I think we're going to all have to expand our networks to keep track of this data, the standards, and frankly, at many sites, by going to different conferences and webinars, you can look for good models and steal shamelessly, because I think there's going to be a lot of learning and a lot of good practices out there that you're going to want to adopt.
Yeah, and I'm thinking when it comes to other technologies to think about and invest, one thing we did was invest in a master patient index vendor, just because we know there's just so many messages coming across each day, and we want to make sure that those are tied into the correct individual. So that's I think most HIEs have a master patient index vendor. You know, I think some of us have tried to do it on our own, and you know, there's folks out there that do this and do it really well, and that's the route we took, and it's been pretty good for us. We're seeing good success with that.
Yeah,
so Arkansas Medicaid is now increasingly developing portals for the practices to get their practice data, but we're working with our claim set, but then we're working with AN as well to then augment that information. So it's increasingly we're expanding the universe of what goes into our data analytics to then go into the portal to go directly to the practices.
Yeah, I was going to say, I mean, it's going to be, there's just with so much, you know, so many different sources of data out there. I mean, it's no longer just going to have my single EHR who can do everything. You're going to have to partner with multiple sides. Now, I know there's a challenge of getting too many, right? How can you support, you know, I mean, so that's going to be the balance, I think, will be the challenge the next couple of years, right? Is how do you, where's that right level of, you know, best of breed who does things really well, you know, and specializes in this versus maybe having too many things. So, I mean, I would certainly look for a technology provider who maybe can do more than one thing. At the same time, I think you find someone who does it really well, then you should work with that person. Let them, if you're a developer of an EHR system, you know what you do well, focus on that, partner with those who can complement you. And likewise, if you're obviously a hospital medical group, right, you know, you want to get people who play together well. But you know, it's maybe a lot to ask your EHR developer to do everything, right? So
I think a good example of that, you know, we have the mandatory or the required, you're supposed to be checking your patients for opioid use or controlled substance use every time you write a script. Well, for a long time, it was a silo of data. You had to go into a separate browser and log in and get the information. It's now integrated into my EMR. And so it's a click here and a click there, and I have the data. Big difference. So when you can start to take a database and integrate that into your workflow, huge difference in terms of functionality and availability and impact.
I think there's so much there, and we have a couple more questions to get through. And I did have a couple questions I wanted to ask you all, but I think we might try to circle back on those, and I want to leave plenty of opportunity for you know, for Q&A. So I'm going to come on to question number 4, and question number 4 is, how can or will cures impact the health IT business model? And I think you all have mentioned that in little sound bites a little bit more, but maybe you could speak to it. I think, Ann, if you would like to address this a little bit, you know, with regard to what's going on with Share Arkansas, and, you know, how you see, you know, changes that might be happening with regard to your business process, business model, that would be great to start.
Yeah, one thing we're seeing, you know, and we have a little saying here at Share, which is axe the facts. I think if anything, I really hope the Cures Act will reduce the number of fax machines at providers' offices. But having payer use cases, you know, has really been important for us, for our sustainability and our continual efforts here in the state of Arkansas. But we've partnered up with health plans to reduce the number of chart chases. I don't want to say eliminate chart chases yet, because we don't have everybody connected, but I think that's an incentive to providers, right? And it's hard for them to see that ROI of making that investment into interoperability. But if you send us your data, we can turn around and we can share that with your health plan. So then, you know, prior authorizations become a little bit easier. Medicare risk adjustment can be done using electronic data now. You know, even maybe some HEDIS reporting can be eliminated, that can eliminate some of those chart chases if the health plans can pull that information directly from us. So I think there's there's a whole opportunity of new use cases. And, and really with that goal of let's reduce the provider burden, let them take care of folks and not be, I don't want to say bothered, but visited frequently by different health plans, because it's not just Medicaid coming to the office, it's not just private, it's everybody asking for similar information. And sometimes multiple times, because you have different departments asking for the same thing to fulfill different requirements. So I am hopeful that data can be used to really eliminate not just the provider burden, but also, that constant chart chasing that all the payers have to do.
And with regard to that, Ann, I mean, do you see having to establish new contracts or procedures with regard to some of the requirements around cures, and the HI component?
Not so much new contracts, but, like I mentioned, just making sure you're documenting your use cases and what exactly that data is being used for. So if you do get a squirrely request for something that you might not think it's appropriate, you can say, this is not part of my documented use cases. So yeah, just making sure everything is documented correctly. But I don't think we need to engage in new contracts.
On the other hand, you are getting payers coming to you with new contracts to help them get with their data collection. So they're finding it isn't a useful business relationship, because that could then reduce their own administrative burden to collect the data directly from office sites.
Mm-hmm.
So there are some business opportunities in that regard.
Oh, yeah, I was just thinking around the data, the data mapping and all that, information in and around the USC, the new EHI requirement. Anyway, yeah. Kyle, what's your take on on business models?
Well, yeah, and I'll just say one follow up too with on Ann. I mean, I don't necessarily think contracts necessarily have to be redone necessarily from this standpoint, but I do think you need to think about the scope creep, right? I mean, if more and more requests are done, like I need this or that, is it, again, what are you really doing? And I think especially as you're a developer, you want to make clear to your provider community, these are things we're doing, this is what we can't do, and this is how we will help you partner with people to do it. I guess, I think about Cure's impact, probably the thing that I am most hopeful for is as we start standardizing about FHIR version 4. I mean, FHIR truly is now version 4 it's for payers, it's on providers, it's the EHR system. I mean, everything is now kind of built around that. And before there was, it's kind of this chicken or the egg thing, right? How are we going to build these various applications to connect with systems if we can't agree on kind of the exact way to do that? And there were obviously some standardizations we had with various HL7 stuff. We had direct messaging, which I think was very successful. But I think once you start having these common interfaces, now you can have common applications that can work across. They have the ROI, right? So you should start seeing, frankly, it's just I think some better innovation, right? There's reasons to invest. I mean, I think ROI has been a true sticking point before. While we had interoperability, has it been worth the investment? And especially with being unknown. Well, now it's getting better defined. So to me, I think that's definitely one thing that's there. And then the other thing I'll just mention about its impact is, I mean, again, I go back to kind of, obviously we've all kind of lived through the birth, at least the explosion in the common world of our common lives with the internet, right? And now so much data available, and just the value of having someone who can aggregate it, curate it, present it in a way. If we now start having all of this health data available, I mean, what are the good ways that that you can get in there to make it really efficient and useful to you? Because you don't, while you don't want your providers spending all their time hunting to find data, you also don't want them drinking out of the fire hose, right? And just trying to, it's overwhelming. I think one thing, in the USCDI, one of the things they added compared to what they had previously in ONC requirements is now just simply clinical notes. They just want clinical notes, the human readable written notes available, because providers get these CCDAs are just huge, and that's really useful in a lot of ways. But a lot of times providers just tell me. I mean, Ann's talked about the facts, and I'm with you about let's get rid of it. But I think we also have to ask ourselves, why has it been so needed? Because sometimes a provider just wants to read it, give me the gist of it, so I can treat my patient and move on. And because I have a lot of other patients coming through, right? So I do think that's one thing in terms of the impact of the business model. If there's too much data available, it can slow you down. So you want to find things that you want to be tailoring your system to where you're getting the right data you need, where you need it, when you need it, type of thing. And that's going to take some foresight, or at least some work. And you're not going to be able to get it right the first time through, but the iterative approach to really improve that, so that the data is there when you need it. And again, I know talking about Dr. Gold, your point about the silos and stuff is totally, I mean, it's still probably the reality, but I am concerned once we open it up, it'll change it too much, maybe.
Separate from the Cures Act, the new CMS effort to reduce documentation requirements is going to be a big help. You reduce the note bloat, and you can find things easier. So that's a help. And one of the things that we've done at Medicaid as we unroll our program is to communicate on a regular basis and give people lead time. We don't suddenly drop a new requirement and say, hey, we expect you to do this, or this is coming at you tomorrow. We get a lot of feedback from our stakeholders, but we generally, don't make a major change. We usually say, hey, this is coming at you, we're going to do it next year. Or we give people time to start thinking about what it means to them, or how they're going to actually make this technology part of their practice environment.
So, Dr. Golden, can I just ask, are you guys making some, is it affecting your business model a little bit? Cures, the way it's coming in, the way you're doing,
Well, since we know that we can get more information, we are using technologic capacity and data as part of our conditions of participation. So, when we first started the medical home program, we said, hey, you all have to have an EMR to be in the program within 2 years of signing up. If you don't have an EMR, this is 8-9 years ago, you're not going to be in. We could start saying if your hospitals are not a part of the HIE, we'll limit, or you're going to we want your patients to be part of the HIE system. There are all sorts of things we could do to push people into the environment where data is shared. You have to have a patient portal. That's part of the CPC Plus environment. So it's those kinds of expectations that transform practice. And let me tell you, when you have PMPMs that you're getting $5–10 a month per patient, people really view that as in part of their core infrastructure overhead, and they want that dollars, and they will. You give them a little bit of a threat in terms of pulling that money away or put them on probation, and they change. They adopt the technology and integrate it in their practice. It's pretty clear.
Okay, I think we need to move on, and thank you very much for that. That was our third question. We're going to move on to our fourth question, and we may need to cut this one a little bit short, but we'll see how it goes. But the fourth question is, what should your respective area, your organization, do now to be ready for cures? So what are you doing right now with regard to, I think maybe I'll start with you, Anne, and then we'll just move through to Dr. Golden and then to Kyle. So.
Yeah, for us, we really wanted to support our providers. We know that patient matching, for example, is really difficult, right? So if you're a hospital and you're supposed to send an ADT out when somebody comes in to that person's primary care physician, you may not know who their primary care physician is, or you may have 3 Dr. Smiths in Little Rock area that you might not be sure. So one thing we did was early on when this first started coming out is approach hospitals that maybe had not connected to us. There was only a dozen or so that had not yet, to really start educating them and talking to them about it and explaining the benefits of, hey, if you send your data to the HIE and send your ADTs to us, we'll take care of that requirement for you, and we'll make sure those primary care physicians and those community providers get that information from you. So we took a we're here to help you type of approach. Our pricing, fortunately, because we do get some funding from Medicaid, we're able to keep that cost really low. We're still a voluntary HIE here in Arkansas. There's no requirement to participate unless you're a PCP and PCMH, but just assisting them, helping them manage those identities, because that's going to be a lot for a hospital, So providers are supposed to go on the National Provider Registry and update their direct email. And that's the email that they're going to be getting those ADTs from under the CARES Act. Well, that we know that the providers a lot of times are not the ones actually taking care of people and doing the care management part of, the transitions of care. So we have processes set up that we could assist them very quickly and help them meet that requirement.
Okay.
I think as a payer, we have an obligation to create forums to keep our clinicians and clinical sites up to speed, get them to understand how the world is changing, how they can prepare, give them lead time, tell folks to lean on each other for expectations. Primary care docs should make referrals to the sites that are part of that health information exchange. If you can't go in your EMR and see what your patients are doing in other clinical sites, that's putting you at a competitive disadvantage. So there are all sorts of things that we can model, we can support, and at the same time as an organization, we need to look for opportunities to integrate data, provide that data to our for our patients in our clinical sites, and model new opportunities to improve care.
Yeah, and I'll just speak maybe from for the EMR, EHR developers, I'd say about 3 things. First of all, the Fire 4 transition, I would start working on that probably now. It's the ONC requirements for the new, it's not just Fire version 4, it's Smart on Fire with all how you kind of the OAuth identity and so on, how you connect in with the apps. Also the bulk on Fire requirement. I mean, to be certified in the new G10 requirement for APIs, it's the bulk on Fire, which is a large volume of patient data, how you get that out. That's that's a whole new kind of thing, right? Start working on that now. I mentioned about inventorying your EHI, part of getting ready for information blocking. Do you know where it is? Do you know how to get it out? Is that, how you get it out for providers and patients? So I would really looking at that. And then third, I mean, I would, if I'm a developer, how can I make my EHR sticky and needed and valuable to my customers? I would find ways to utilize this data that's available, right? I mean, these aren't certification requirements, but can you build in apps or support services that helps you do the things to make advantage of all the data that's available, do the prior auth stuff, claims data. If you can pull that in a way that makes it, available to your clinicians and that's useful, they're going to love you, or at least not like you a lot more than they like you maybe now even. So those are the things I would probably say I would start right now on if I was a developer.
Okay, can I ask a quick follow-up on Fire version 4, as you were speaking to? Is that a heavy lift for health, for IT departments? And what would be a reasonable time frame to get that in place?
Yeah, I mean, obviously it varies, right? I would say my thing is, if you were going to, if you think about developing it, I'm gonna presume you already have an API, maybe you already have some version of Fire right now. Developing it, getting it tested, certified, rolling it out. I mean, I would probably put a year of that, right? I mean, because again, it's not just it's certified, there it is, right? I mean, you need to put it out there for your customers, make sure they're able to use this now. I mean, these are there's expectations on this. So, I mean, I think 12 months is a really an appropriate window. You can develop it sooner. You can get it done in less than 12 months. That depends on your resources you have available. But just the people I've talked to already, them thinking through it, I mean, they've been putting in, a good 9 to 12 months. I'm not saying you have to start immediately right after this webinar, but I would be looking at it. It's not a small lift.
Okay.
So wouldn't you say, though, you shouldn't ignore it, because at some point you'll be at a competitive disadvantage?
Totally, yeah, and it's definitely something that you can't, there's been other certification requirements, to be honest, that you could probably just, all right, we're gonna cram in this month, guys, we're working weekends, we're gonna push this through, right? This is more of an architectural approach, right, that you need to think through, especially with the Smart on Fire and how you're supporting the various, identity management authorization things. So yeah, I definitely think, Dr. Gold, I would say one thing after this webinar, if you've not done already, is I would start strategically thinking about it. How are we going to do it? How am I going to line up my resources? Because it's going to take some time.
Okay, and I've got one. I think we have time for one more follow-up question. I just wanted to go out to Anne regarding documentation and use case pricing structures. What kind of strategy are you using to educate your your community? What is the most effective that could be parlayed by folks on, in attendance here?
Well, I think for us at SHARE, we're in a little bit of a unique situation because we were a state agency and have been for a long time. So everything we do is very full and everything is very transparent. So I think our providers are well aware of pricing. But one thing that has been beneficial to us is approaching, because we know there's always going to be a cost with EMR vendors, right? Whenever it comes time to creating interfaces. One thing we've seen success with is having EMR vendors create hubs that, whenever a provider uses a cloud-based EMR, so all the data is sitting there in the cloud. So creating a hub where all the data for that one EMR is housed at that one cloud base, and then just having one interface to the HIE has been really helpful with reducing the cost to the provider. So we at SHARE, the HIE, we invest some of our own funds to create this hub, and then in return, providers get a better cost from their EMR vendor. So trying to find unique ways to eliminate some of that pricing part that the Cures Act, information blocking, yes, it's great. They did a good job on that, but there's always going to be a price and a cost. So trying to find ways to support our providers, helping them meet those requirements at something that's not too expensive. So, we have made phone calls to our payer friends and said, hey, we have somebody here that really wants to connect, and they can't, they have a cost barrier. And guess what? The health plans are willing to support that because they see the benefit in the long run. They get access to that data as well. So being creative with pricing, it's helpful.
Okay, thank you very much. I think this has been a great discussion, and at this time I want to turn it over to the Q&A for any questions that have come in, and that will be facilitated by Lori.
Thanks, Patrick. We have several questions, and so I'd just like everyone to know that if we don't get to your questions, someone will reach out to you directly following the webinar to talk through the answer with you. The first question for the panel, Matthew would like to know if you can talk a little bit about enforcement relative to information blocking. Who enforces and what form do the penalties take?
Sure, I'll speak a little bit about that. A little bit is in flux a little bit. So information blocking has come out from the ONC, and currently, because the government works off final rules, right? Not just proposed rules. That's the structure. You propose a rule, comment period, finalize it. And right now, the only thing that's finalized really is ONC has this rule in place for information blocking, which we talked about. And so, if I'm an EMR developer, that's impactful right now. I could get a non-compliance. Obviously, any kind of non-compliance could ultimately lead to possibly decertification, worst case scenario. Or even best case is just you have to fix it and resolve it. If you're a provider, you do have to make a attestation that you're not being an information blocker as part of MIPS. So I guess if you were found later on as an information blocker, there could possibly be some, ramifications in terms of reimbursement you got. The penalty parts that we have, that right now is currently only in a proposed rule from the OIG, and it's just for developers. So it's actually not finalized yet. So you hear these things like $1 million fine that has been proposed potentially, like the maximum fine for information blocking. It's not been a finalized rule yet. We're not sure when that rule will be coming out exactly. So, I mean, I would say, Matthew, that is though what is on the horizon. Everyone's expectation that they will finalize that, and they will have some kind of the civil penalty kind of approaches for this. There's not any current proposed rule for financial penalties for providers yet. Again, but their concern, of course, is that they were information blockers. They were like in a MIPS program. They found, later on, could that just be like if you falsified your results, in a MIPS calculations, right? So those would be the risk, frankly. It's obviously not something that you want to put yourself subject to.
Okay, thank you. Next question. How should providers leverage Cures to improve interoperability around the data-driven activities aimed at improving the patient's experience and reducing cost?
Who would like to take that one?
Like one thing you talk about as far as, patient experience, there's been, this idea of clinical notes. And actually a lot of people kind of have thought that, this idea of open notes, that clinical notes have to be automatically pushed out to the patients at every time, whatever, something happens. It's actually not what the OC's even confirmed. That's not really what has to happen. It has to be available upon request. But I think it relays the fact of an important idea that if we're going to do this, let's actually do this in a way that really, it's not like certification, as I mentioned, where it's just a box to check. It's a little more open, right, about this access, exchange, and use of data. So I would really develop this and do things in a way that you think provide value. I mean, really use this as an opportunity. What can we really do that actually really will help the patient? So there's not necessarily a one size fits all. Dr. Gold was talking about that. It depends on the situation. So look at it. Use that sort of malleability within this information blocking kind of aspects to do things that really are going to actually provide valuable.
I'll give you some examples. I mean,
Okay.
if you're a
Yeah, I
hospital.
think we lost our internet here in the office.
Okay,
Okay.
we got some back. We're kind of on data lag here. So the, if you're an ER, if you're running ERs, you could, there's resource management can be significantly impacted if you can access, your ER staff can document what's been happening to that patient in other locations. You can reduce CT scans, you can reduce, if you will, the guesswork and the laboratory work. There are all sorts of network, ACO, total cost of care issues that if you are taking advantage of networked information, you can really have a much leaner care plan with a lot of repetition being diminished. Likewise, Ann and the HIE, they're doing ADTs on a regular feed basis to all the primary patient-centered medical homes. So every day now, these medical homes are getting who's been in the ER, who's been discharged from the hospital, and they're reaching out and trying to get people back into the system so that they don't have repeat visits or deterioration of a stabilized condition. So there are all sorts of opportunities in that regard that information blocking can improve, or that reduction of information blocking can improve.
Thank you very much, Dr. Golden, and thank you for the panelists. Lori, I think we're at time here. I'm going to just go through and thank everybody for participating. I have put some resources up for everybody, that is available. That'll be in the deck, and these are great resources. ONC's done a great job. And also, I just want to just close with saying again, thank you to the panelists. Thank you, Ann, for joining. Thank you, Dr. Golden, and thank you, Kyle. And if you have attendees, if you have any questions about this topic, which I think we'll probably have to do a part 2 because it's so deep, you can contact us at Secure Exchange Solutions, info@secureexchangesolutions.com, and you can also contact Lori at his talk, and we'll connect you. We also will be having a white paper forthcoming with regard to some of this content and some of the things that we discussed. So we will make sure that attendees all get an opportunity to have access to that. And again, I really want to thank everybody for joining us today and participating in this presentation. So with that, I think, Lori, we're probably at time, aren't we?
We are, and thank you, Patrick, for wrapping it up. Again, thank you to the panelists for the interesting and informative discussion. So I wish you all a terrific rest of your day. Bye-bye.